Hello, this is Jim Szyperski, and welcome to Mental Health Care Today. Today, we're delighted to have a special guest, Dr. Eric Storch. Eric is the professor, vice chair, and McIngvale Presidential Endowed Chair at the Baylor College of Medicine. Dr. Storch is an experienced professor, researcher, and clinician who has devoted his career to work in obsessive compulsive disorder and related disorders. He has a demonstrated history of working in the higher education industry. He's skilled in clinical psychology, research, writing, science, editing, curriculum development, and public speaking. Dr. Storch holds a Doctor of Philosophy, PhD in clinical psychology from Teachers College of Columbia University. Eric, thank you for joining us at Mental Health Care Today. It is a delight to have you on.
Absolutely. It is a pleasure and honor to be here with you.
Well, let's jump right in. Most of us have all heard about obsessive compulsive disorder, short name OCD. We've heard jokes about it. We've seen it on television. We've seen it in movies. But can you take a few minutes and just tell us about OCD, what it is, and how prevalent it is in our society today?
Yeah, I'm glad you asked that question. OCD by no means is a joke or a laughing matter. So this is the condition that affects about 1% of the population across the world. What's also interesting is that it usually ranks in the top 10 leading causes of disability by the World Health Organization. So a massively impairing condition. If you don't do something about it, then we tend to see it escalate in course, conferring this really lifelong disability, not only for the person suffering, but the people that love him or her.
Interesting. Is there a certain age that you see this manifesting? I'm thinking of a parent out there or a family member and with children. What age do you see it manifest itself, and in what sense, and what types of things should I look for instance, if I'm a parent? Symptomology?
Yeah. Well, a couple of great questions within that. So if we think about what OCD is, there are a few different hallmark features. So one of them are these obsessions, which are these unwanted, intrusive thoughts, images, or impulses that bring about distress and anxiety. And then they tend to motivate this behavioral response called compulsions. The behavioral response can be things that you see, like washing your hands or doing something repetitively, or it can even be stuff you don't see. So one example would be avoiding things that make you uncomfortable. Another would be things like counting or praying, or arranging things in your mind. Now, these symptoms go together, the obsessions and compulsions, but they can manifest in a lot of different ways. So one of the ones that you pointed out earlier that we all sort of know about are these germ fears, contamination fears, and then associated washing. Another one involves this kind of, perfectionism, neatness, symmetry, order that then links to, ordering things, doing things over and over again. But there are a few others that are really, really common, but people don't speak about them. Now, one of these involves things like unwanted, intrusive, taboo thoughts that could focus on things like sexuality or harm or aggression. So the sexual stuff could be someone having fears that they could molest someone or be a pedophile, or questioning, are they straight or gay? Just as some examples.
Mm-hmm.
The harm obsessions could focus on, could I do something to hurt someone else? Like, did I drive my car and swerve it and hit someone? Or if I take this knife to cut my steak, maybe I reach out and I stab a family member. But what's important about these symptoms is that the person absolutely does not want to do this. There's no risk of them doing this. And rather, they're just really distraught by the nature of these thoughts and the potential of it happening. So those are a couple common ones. And then there's a final kind of grouping, which involves this element of scrupulosity. So fears of offending God or doing something morally wrong, things sort of like that. Now, this is all important to understand in terms of that question that you asked of how often, when does this kind of onset? So we see sort of a bimodal distribution of onset. So for about 50 to 70% of cases, symptoms do start during childhood, pretty often, at 10, 11, 12 years of age. And again, over time, it almost runs a stock market type course of getting worse and worse, but with some periods a little bit better, some periods a little bit worse, but sloping positive. Now, there's a second grouping that often happens during early adulthood. Now, in some cases, some of these concerns or symptoms emerge when a woman has her first child, where we actually see about 6% of moms have onset of postpartum OCD. But other kind of factors could be, just the way the brain matures and changes over time. Could be increased responsibility with adulthood that takes place. But in general, this kind of bimodal distribution, with the majority having a childhood onset of symptoms, but then another kind of sizable subgroup in early adulthood.
And I assume, like most things, there's a scale of severity that goes up depending on where you are in that spectrum or during the time that you first are diagnosed and on. Are there, I guess, are there things what are some of the more accepted methods just to work with someone, particularly someone young? I'm thinking to your point, someone 10 or 11. And are there things you can do to help slow or halt that escalation scale? Because I imagine if, like most issues, if it's not treated, then it may multiply on itself, or is that incorrect?
You nailed it. So if you don't treat OCD, in most cases, it persists over time. And we can talk a little bit later about some of the treatments which exist, which are very effective. But the way that we diagnose is by having a mental health professional, like a psychologist or psychiatrist or therapist, conduct a clinical interview with the individual. Now, a core component of that interview is a measure that actually one of my close colleagues, Dr. Wayne Goodman, and I had created, called the Yale-Brown Obsessive Compulsive Scale, where there's an initial edition and a second edition that we published about a decade ago. Now, what this scale does is it assesses the types of symptoms that people may experience, as well as the severity of those symptoms, which then gives us an idea of sort of how problematic this OCD is. In kids, we really want to embrace the whole family, even in adults for that matter. So, I always recognize that if you ask me something and then ask my wife something, we might give two different answers, and she's actually the correct one, I've learned. But we want to make sure we're getting every kind of angle on the nature of OCD symptoms, which is particularly relevant in children who may not have the same kind of sense or ability to think about their OCD as their parent does, who is observing them.
And just really for our audience, if we don't, to your point, don't test and diagnose for these things, or like what is the adverse slope of that? What happens? What are some of the things that can downspin from that, for instance?
Sure. What's been really problematic in the OCD world is that kind of latency between the onset of symptoms and the first treatment, not even necessarily the right treatment, but some estimates have put this as between 7 and 10 years. So just imagine for a second that you had cancer and you waited 7 or 10 years to do anything about it, maybe not even the right thing. I mean, so what we see with individuals is that they've missed out on huge chunks of their life, going to school, being successful in school, building relationships, trying out and practicing romantic relationships, or finding, a soulmate over time. Reduced occupational success is another factor. And on top of that is really the myriad of psychological problems that can happen as well. So very often we see depression affecting people with OCD just because it stinks so much to feel anxious all the time, or to know that you just can't function at the level that you want to function because you have all these symptoms and rituals and so on. So we tend to see people who really have had a complex course when they have had that kind of reduced, that delayed kind of diagnosis at play. On the other hand, when we're able to intervene more effectively earlier on in the illness course, that really gives us a better prognostic outcome because we aren't having to rehabilitate the person who's struggling with this so much.
Yeah, and I'm glad you brought it up because one of the things I think our audience should know is that both the Y box or the Yale Brown Obsessive Compulsive Scale and the children's version, the Psi box, are two of the most renowned measurements on the planet. And you're as a co-author of that. I mean, can you tell us a little bit about, because we're obviously at nView, we're very, very bullish on screen everyone, start screening early, catch all these things early if you can. Can you explain a little bit about the tools themselves and why it's so important for a healthcare provider, not necessarily even a psychologist or psychiatrist, to get these kinds of tools in their hands?
Sure. What the white box did, which I think was revolutionary, was it really focused on assessing the symptoms that compose the condition, but capturing how we conceptualize the associated severity of that. So the white box truly has been a model for multiple other severity scales that to date hadn't really been published or created outside of OCD and in so many other domains. So historically, the way that the severity of diseases, different disease states was captured was you looked at all the symptoms, you asked how bad the symptom was, and then that summed it up. So for example, in depression, you might say, well, you have problems, concentrating, 0 to 3, how bad is that? With 3 is the worst. Well, you're 3, okay. Feeling depressed, well, how bad is that? 3. And then you sum all those things up. The problem, however, with that approach is that it provides this kind of weighting on specific symptoms that may not correspond with overall symptom severity. So if someone has problems with falling asleep, but also sleeping too much, you end up seeing the likelihood that one of those is going to be scored differently than the other. But all these collectively are summed to get an overall composite severity score. Now, the Y box takes a different approach. It really focuses on, again, what symptoms are present that link up to the illness, but then this element of how we would conceptualize severity. And the way that it conceptualizes that is in terms of the amount of time affected by your symptoms, the impairment affected by your symptoms, the distress caused by your symptoms, as well as your ability to effectively control them. And so this has been something that's really kind of withstand the test of time as a way of thinking about the severity of an illness. And then, as mentioned, multiple folks across different illness states have taken this model and applied it to the way that they think about assessing the severity of their respective disease.
That is just great. That's terrific. And it's just great work and so desperately needed. Next week, we start May, and May is Mental Health Awareness or Mental Health Month. And we're really trying to, at least at nView, and some of the things we're doing is try to move people past awareness. I think most people on the planet are very aware now that mental health issues are rampant and have been accelerated by the pandemic on many levels. And we're trying to move past awareness and really a call to action to start fixing things and start repairing the system, because there's just been this giant gap between healthcare and mental health care. In your opinion, I mean, what are some, why are some of the reasons you think our system is broken the way it is today? You've been around it a lot, certainly a lot more than we have. And what are some of the things you think we can do to start repairing it?
Mm-hmm. Well, I think there are a number of challenges, and at the same time, a number of reasons for optimism. When I started in this field about 20 years ago, it was next to impossible to get anyone with OCD good care. So when they would come visit me, essentially everyone was treatment naive. They hadn't had access to good quality exposure and response prevention. At best, maybe they had solid pharmacotherapy. Now we're seeing that different. We're seeing a broader number of clinicians out there trained in this space. We're seeing increasing access to treatment. And then we're still seeing advances in terms of understanding illness pathology, but also how do we relate that to our treatments. So that's awesome. We're also seeing this secondary in many ways to COVID, this kind of increased frequency of telepsych, where folks are really appreciating the ability to do this from the comfort of their home without having to get childcare if they're an adult, or be removed from school if it's a kid. So lots of reasons for optimism. On the other hand, there are challenges. Stigma remains, and so that is a big thing for many folks. Cost is a huge barrier. While we may have achieved some successes within parity of mental health to physical illness, the reimbursement rates by insurers still tends to be pretty difficult. So for most providers, it becomes a sort of a choice or a challenge between kind of the way, do they accept insurance, but have their rates dictated, and then have to process that, versus a self-pay type arrangement. And so this really is sort of an issue there. One of the other challenges that persist is really the nature of training. So we're fortunate to have a field that has many, many brilliant clinicians across the range of medicine and psychology. But at the same time, there are often different ways of providing training that may or may not be linked to the illness, or really robustly tested. So if you take the case of OCD, just because it's one I know, we know that there's a specific type of psychotherapy that works really, really well. But not everyone does this. And if you're looking at your insurance, it's often going to be a challenge to find someone outside of a medical center who's providing this type of treatment. And so we need to be mindful of in psychology and psychiatry, that we need to, in essence, provide the most effective treatments that have a robust evidence base, exactly the same way that we would want to do so in any other discipline of medicine.
Wonderful, wonderful. Well, Eric, I want to thank you for being with us. And for those interested in learning more about your work in the field of OCD, are there some good resources you might direct them to?
Well, sure. I will say that could certainly help anyone go to sleep. But what I would just do is look at the International OCD Foundation, which has an incredible array of resources and articles by numerous scholars and leaders in the field.
Eric, I want to thank you again for being with us today on Mental Health Care Today. And I want to thank you in the audience for watching today. For those of you interested in learning more about the work at nView, please visit us at www.nview.com. Thanks again.